First of all, I'd like to thank Dr. Partha Biswas sir for giving me this opportunity. Okay, so we have mirror. Okay, so it's still not coming properly.
We'll do a quick roll call in the meantime.
Yeah.
Is Dr. Nivian here? Dr. N. Nivian? Dr. Anand? Dr. Anand Parthasarathi? Dr. Kudlu? Dr. K.P. Kudlu? Dr. Sean Chinchole? Dr. Subodh?
Okay,
please
I'm
carry
ready.
on. Yeah.
So you have one of the best industry leading optical biometers, be it like Zeiss IOL Master 700, Landstar, or now Tommy, all based on the swap source. This doesn't matter whether you have these all the beautiful, expensive femtosecond laser platforms and you have used these all the premium IOLs. Still, defective surprises are gonna happen no matter at what institute and which private practice you are working. So why do they occur? First, you need to understand that. The most common factors are the inaccurate IOL power calculation, especially in challenging situations like when you have a long eyes and short eyes, you have a previous history of refractive surgery, there is a pre-existing astigmatism which you have not taken up if you don't have the good topographer which is not considering the posterior corneal astigmatism. So all these things will require you to undergo for the enhancement surgeries for the refractive surprises. So what do we do? Usually, not all these surprises require the management if the patient is quite tolerable, because there are a lot of patients who are non-demanding. You can still get away by giving them a small correction, an option of monovision. But if not, you have to open this big Pandora box. So what are the options to treat? First of all, I would like to explain based on the duration. Suppose if it is early, then you have to do the limbal relaxing incision, which you can do always manually. And with this now femtosecond laser assessor platform, you can customize it in endless limit possible. The second is the IOL exchange, and in case of there is a wrong axis, you have put your toric IOL, then it requires the IOL rotation. And late, I would like to say the PRK LASIK and smile and the piggyback IOLs like the Sulcoflex. And based on where we perform the surgeries, it is divided into the corneal base and the lens base. So let's discuss them one by one. The first is limbal relaxation incision. There is no secret that it's a beautiful procedure if performed well. So basically, up to 1.5 diopter of the astigmatism, it works very well, even with the manual ones. But for this, I will advise you need to have the good topographer, which will show you where is the steepest axis, and you just put it over there. Another thing is the IOL exchange, which I think you should reserve for the extreme of the cases where you have the significant, refractive surprise. And even at all you have to perform, it has to be performed within the 3 to 4 weeks max before the capsular fibrosis or adhesions have occurred, because it carries a significant risk of the capsular damage as well as the rend leading to the edema and the RD. Here I'll be quickly showing you one video. The courtesy goes to Dr. Baba. So here the first thing you have to do, this was performed I think after 4 weeks. Patient had history of previous refractive surgery and there was a refractive surprise. The first thing you do, you have to put the adequate amount of the OVD's viscoelastic substance in front of the lens as well as the back of the lens. So whatever adhesions are there, they will be removed by this visco insertion. So we call it a viscolysis. So once you have done that, you go just behind the lens, you just slightly pull one of the haptic out. And then you take these micro scissors. One can use the MVD, and there's another one is just the normal scissor. The trick here is to cut the lens to up to 90%, or I would say 3/4. You don't have to cut the lens into 2 pieces. Otherwise, it becomes uneasy to control it. So once you have done that, here you can see he has cut the lens up to only 90%. Then you just slightly snatch it out for the same incision. Even you don't have to enlarge the incision. So once the one portion is out, you can always remove the other one very easily. And then you just reload your next lens, just like you are doing a normal cataract surgery, and it's done. What about in case of the toric IOL? Like I mentioned earlier, the main problem is the residual cylinder. That happens because you have failed to consider the posterior corneal astigmatism in calculation. But nowadays, with these advanced calculators like the Barrett's toric calculator and the Heal's RBF calculator, they have taken into the account. And as I told you, if the cylinder is more than 1.5, then you have to take care of the options like LASIK and all. I suppose you have this toric IOL rotation and all, then I would like to quickly show you one site which will help you fix it. It is known as the astigmatismfix.com. Even it is also available on the ASCRS site, where you click on these formulas and you get all those options of the Barrett calculators on. There is one thing is there. Or you just simply go to the astigmatismfix.com over here. You just enter the patient's name, data. Here you have to write, this is where you have to write what was the previous patient's axis. Here you just write the manifest, what is patient's manifest refraction right now, and what was the IOL plane selected, IOL corneal power which was selected at that time. It will give you the beautiful options, all the lenses, the industry leading like Alcon, Johnson & Johnson, even Bausch & Lomb and the Star as well. So once you have done that, just click on the calculate over here. And it will give you this thing. So initially my lens is placed over here, and it is suggesting that it requires a 14 degree of the rotation. So this is how you can work out. So again, I will tell you the site name is astigmatismfix.com. So what about the correction for the low power? As I told you, the LASIK, PRK and the SMILE, nowadays they take over. So when you perform, that is the most challenging thing. In case of LASIK, I would like to at least wait for 2 to 3 months once your eyes are quiet, and or you have at least minimum 2 stable infections. Let us see in different challenging scenarios. Suppose you have you have inserted the monofocal IOLs, you have the refractive surprise of hyperopia. So usually for the initial 2 to 3 days, it can be due to the retained viscoelastic. But if it is suppose more than one diopter and a bit less than 3 diopters, then LASIK would be my first choice. And if it is more than 3 diopters, then other things take over. In case of myopia, again, as I told you, you can offer the monovision up to 1.5, but it is more than 1.5 and under 6, then you have to go and perform the LASIK. And again, I told you, you have to wait for at least 3 months for everything to get stabilized. What about the profile which we should do if you are correcting this refractive error? So I would say you can use all these premium profiles like the topo guided nowadays. Contura is the new kid on the block. So you can use the normal one as well as the Contura ones. Cylinder I have already discussed. What about the multifocal IOLs? The only different thing is you can do just like you are doing with the monofocals, but I would advise you against doing the wavefront guided treatments as well as the Contura, because there is already multifocalities there, and by doing this treatment, first of all, it is difficult to acquire the images for the wavefront as well as the Contura. It doesn't work well. Now for the piggyback IOLs like Sulcoflex and all, what are the indications? What are the prerequisite, I would like to say? Now, first of all, you need to have a stable PC IOL with the intact capsular bag, normal or deep anterior chamber, normal endothelial cell count, and no evidence of the pigment dispersion syndrome. And if you have anything like zonules or posterior synechia or reduced endothelial cell count, that's a big no-no. We all know how the Sulcoflex works, so I'm not going into the details. The commercially now they have this monofocal toric, multifocal as well as a trifocal available. I'd like to quickly show you how to calculate the IOL, piggyback IOL power. That is the most challenging thing. The simplest way in case of the hyperopia, you just have to, it is like this spherical equivalent, and just multiply with the 1.5. In case of myopia, spherical equivalent, you multiply with 1.2. There is also the Gill's nomogram which works pretty wonderfully well. And lastly, I have this video, credit goes to Michael Lemon, where he has inserted the trifocal Sulcoflex, which is the new kid on the block. So it's just like a normal, here you can see this is a pre-existing IOL is there. Only thing, the prerequisite, as I told you, the posterior capsule should be intact. So you just like you're performing a normal routine cataract surgery, you just insert the OVDs, and then you load the lens, you fill the cartridge with the viscoelastic, just put the lens in a correct orientation, and just slightly, just slowly you inject and see the orientation is correct. There is no rocket science in this, it's pretty simple. Only thing is the calculation of the IO power. So every procedure is plus and minuses, so you have to select them wisely. And this is how I like to go. Suppose I have a refractive surprise error. As I told you, being in-house, we have this in-house excimer as well as the femtosecond platform. LASIK and PRK and SMILE works wonderfully well for us. So if the patient's refractive error is less than 6 in case of myopia, and in hyperopia up to 3, and there is absolutely all the normal parameters, then we'd like to go ahead with the LASIK. If no, then we'd like to go ahead with either the IOL exchange or the secondary piggyback IOLs. Thank you very much.
Thank you, Dr. Shah. That was brilliant. You covered everything that can be, take all the techniques that can be used to correct refractive surprise. So I would just like to ask you one question. Which possibly is your go-to procedure if you have to choose amongst all of these?
LASIK, ma'am, because I have an inbuilt LASIK as well as the femtosecond platform, so it becomes very easy for me. Because Sulcofil is also costing me in LASIK. I have so many patients lined up, so it doesn't cost me anything extra. So just for the financial purpose, I think LASIK, because I have the in-house. But suppose if you don't have that, then I think you can do Sulcoflex was pretty well as well for the higher ends.
So basically, the bottom line is that possibly a corneal procedure, then a intraocular procedure. Yeah. So because that has its own disadvantages. Thank